being with you today, even virtually in Mexico. My name is Nikolai Pev, and I'm one of the consultant neurosurgeons and spinal surgeons working currently in Belfast, Northern Ireland. I'm going to talk to you today about the...
I knew that
Nikolai has sent his video, so it's all right.
Dr. Nikolai Piv, I want to apologize with you because I knew that you were going to be in a surgery room, but
this is the recorded video.
We are very kind with you to join us. Thank you so much. Go ahead,
Victor.
Dr. Nikolai.
Sorry, Victor, sorry. This is recorded video of Nikolai. He's not here at the moment, but let's play his video. He's recorded it, sent to us. So we'll play this.
Okay. Thank you so much. Thank you.
Decisions in spinal surgery which are more important by the incisions. This is where I am coming from. This is Belfast, and you're mostly welcome whenever this is possible, hopefully in the nearest future. And this is the university hospital I work in, and this is the medical university. We have a nice facility which we tried. We can organize a good interactive courses, and hopefully that will be the future. So I'm going to present to you today a case of a 19-year-old girl who first was diagnosed in 2011 with a slow progressive spinal tumor in the cervical region. It started initially with neck pain, and then it was diagnosed to be a tumor that is inside the spinal canal, and it's going through the exiting foramina inside the paraspinal soft tissues in the neck area. In 2015, the lump was palpable through the skin, and she had minimal left-sided weakness only on provocation. This is the MRI scan that we have done for this girl, and this is the findings. You can see a tumor that is significantly compressing the spinal cord, and there is a significant mass in the soft tissues in the paravertebral left-sided space. This is the CT scan that we have done. You can see that two levels are destabilized by the tumor. C5-6 facet is missing, and C6-7 facet is missing. The vertebral artery is displaced medially by the tumor. Luckily, this is non-dominant site of the vertebral artery. I have done a midline incision, and I have tried unilateral approach. You can see this is the midline which I have preserved together with the bony tissues and the ligaments to prevent destabilizing the patient's neck. This is midline, this is left down. The tumor was excised completely, and the capsule was excised as well, and literally with the last bite that I had a major vertebral artery bleed. Managed to stop the bleeding initially with my finger and then with some hemostatic materials, and then I had to transport the patient to the cath lab for embolization. As you have seen, the tumor was quite big, and there was a huge cavity there, which I had to fill with something because I was quite apprehensive that the patient may rebleed during the transport to the cath lab, and I can lose the patient. Having in mind that I have already lost 2 liters of blood for about 20 minutes, This was not something that I wanted. That's why I decided to pack the cavity of the tumor with swabs and to close the wound like that, and then to transfer for emergency endovascular treatment. As you can see, these are the coils which were deployed to embolize the two ends. Patient was stabilized, and then in 48 hours, the swabs were removed with another short surgery. And then the question was what we do next. We do, before we continue, I just wanted to remind you the segments of the vertebral arteries, 4 segments. There is different segments which we will skip because this is not the scope of this lecture. We have to think also about the variations of the vertebral artery. You have usually left dominant vertebral artery. You have right dominant, which will be about 30% of the cases, and you have codominant arteries in about 25. In about 5%, you have anomalous course. Mostly you expect below the C1 arch, but you have to be careful that this might not be the case as well. These are some variations. You can see kissing arteries, which are going inside the vertebral body. You have to be very careful if you're planning to take that vertebral body. It's a nice research which I have found on the vertebral artery ruptures I wanted to share with you. This is a research that was published by the Cervical Spine Research Society. They have managed to recruit 141 members, and among these 141 members, they had 111 vertebral artery ruptured out of a total of 163,000 cases. So out of these 111 vertebral artery ruptures, with about 90% of the patients, nothing happened. The majority of them had no sequelae, and then about 2.7% had minor neurological deficit, which resolved. But still, you have about 5% died, and you have 5% with permanent neurological deficit, which is a significant percentage still. If you look at that table, you can see that the biggest percent of the vertebral artery ruptures occurred with the upper cervical C1, C2 spine fixation. Then you have corpectomy, and then you have the posterior approaches. So this was my case after it was embolized. You can see the coil actually here going up the vessel. You can see the coil protruding out of the vessel, and it was possible to see that when I was removing my my swabs. I'm sorry, I have no pictures of that to show you. But most importantly, after this, I was left with the decision, what should I do with that neck? Because that neck was clearly unstable, and we had to do about that. This was again a 19-year-old girl with a long and flexible neck, and I was worried about that. You can see that I managed to remove the tumor with only hemilaminectomy, so I managed to preserve the midline structures, but still we had very soft discs, and we have C5-6 and C6-C7 facets missing on one side, and this for me was a big problem, and I wanted to sort it out. I have discussed this on our multidisciplinary meeting. I took opinion from my colleagues, spinal surgeons, and they have advised me to go for C4 down to T2 posterior fixation. You would understand that I was not very keen to do that on this 19-year-old girl. That is why I have decided to go against the MDM discussion and advice. And I have designed my own option, which was a little bit off license, but you will see that it worked. This is how I decided to fix the patient. I have use 2 zero profile cages, which you can see here on the right side of the screen. And then I decided to plate. I have used with this girl the smallest zero profile cage, which was only 14 millimeters long. And this was possible for me to do fixation of the fixation of the neck, but because I was worried about the possible kyphosing, I have decided to go further and to provide some buttressing with a plate. You can see, even though I have used 14 millimeter cage, you can see the posterior line of the cage lies nearly close to the posterior vertebral line. So this was really close margin for me. Another thing that I was concerned about is that the vertebral bodies were partially eroded from the tumor, and that is why I have decided to use these zero profile cages with fixation, because I was concerned that the cage may displace and compress the spinal cord, which obviously was not wanted. This is my 1 year follow-up. You can see that fusion is already happening here, and on the standing x-rays, the patient is not kyphosing, which was good enough for me. And this is the postoperative MRI scan. Obviously, you can see a pseudomeningeal cell here, which is completely neurologically, it was completely silent clinically, and I was not concerned about that. Having in mind that this was a big tumor, no wonder that we have this pseudomeningeal cell. So 2 year follow-up. This is how that neck looks at 2 year follow-up. And at that point, I have discharged the patient, and she was happy. You can see still the coil here. This patient now is in Australia, and she has a normal life. Another case I wanted to present to you today. This is a 40-year-old patient diagnosed with rheumatoid arthritis, with signs of progressive myelopathy and increased spasticity, balance problems, frequent falls, pathological reflexes present. So clearly, overtly myelopathic patient. You can see on the X-rays that there is 10 millimeters distance between the anterior arch of the atlas and the dens. You can see the change of the distance between the C1 and C2 on flexion extension X-rays, and you can see clearly the compression here on the MRI scan. So clearly this patient needed fixation, and we had to decide which option should we use. These are the most common options which most of us will continue: transarticular screws, bar screws, C2 pedicle screws, and C2 laminar screws. Considering that, we have to think about the biomechanical stability that we will achieve, and we have to think about the safety of the patient as well. So there is a good publication which I have found on the mechanical stability, and from this paper you can see that the transarticular screws augmented further with C1, C2 wiring is giving you one of the best stabilities in all directions. And the other consideration which we have mentioned is the safety for the patient. And this is, again, that slide which you saw with the previous case. You can see here that the posterior instrumentation of the C1, C2 is giving you the highest chance of possible vertebral artery injury. But if you have to do it, you have to do it, and sometimes careful consideration will help you to do even procedures which are considered a bit more dangerous. This is how we fix the case. First, we have wired C1, C2, and then we put some bone graft. And after that, we have placed C1, C2 transarticular screws. And the patient did well, and there were no problems afterwards. So to conclude, lessons learned from these cases. Studying the imaging carefully preoperatively is a must, because by studying carefully the images that you have, you will spot the possible dangers, and then you will prevent complications, because prevention is best than dealing with the complications. Endovascular service handy is important for you to have in case you're doing these cases. In cases when, hopefully rare cases, when you will have bleeding, you have to first try to stop the bleeding with anything you have, with swabs, with muscle, with your finger, with anything that is on your disposal. And then you have to think what else you can do. Usually you have to think out of the box, because these complications and these cases are not very, very often. You don't have so much literature to read about that. You don't have guidelines. You don't have consensus. The only thing that you have is expert opinion and your own experience. So this is from me today. Again, thank you for the opportunity to be with you today, and I will be happy to answer questions. Thank you.
Thank you, Dr. Salman, to present this lecture. So I think it was an unusual case about this kind of tumors. And I think one of the arterial vessel most important in these cases is the vertebral artery. In this case, it was an hypoplastic vertebral artery. I think this was an advantage. As we have heard, the mortality in these cases is very high, about 5% is too much. So what's your opinion, dear friend Salman and dear colleagues?
So I think in this particular case, actually, I know this case because when it happened, I discussed with Nikolai and he shared this with us. And our first thing was that the lesson learned from this, if you've got a tumor like this and you've got tumor engulfed, taking all the vertebral artery, then you need to be thinking that to see, is it possible to sacrifice it or not? And the way to do it is to do an angiogram, obviously, and find out if it's dominant, non-dominant, and you put up a balloon and see, can you sacrifice it or not? So that's one thing that we should learn. If you've got a tumor like that, then that's the first thing you should do. So that's for all our juniors and for everybody who has a scenario like that. So that's the most important thing that you should be aware, that can you sacrifice that artery? So if we had known beforehand that you can, then that's a possibility that you take out the tumor completely and safely take the vertebral artery from both ends. So that could have been an easier option instead of running into all this problem. Regarding the fixation technique, again, too much of hardware is never a good thing. Nikolai got away with it over here, but if you've got 4 screws going into a small cervical body, then that's not a very good thing to do. And especially if they're parallel, then you can run into trouble here. Obviously, he left this patient in a collar for a very long time. That's probably saved him. But I think if you have a scenario like that, then we discussed this, then I would probably not use what he used, but what worked for him obviously does the best. And that's what we have discussed. Regarding the second case, it was, I think, straightforward case. And what we generally recommend is for our juniors, that what we need to do is put in C1 lateral mass and C2 laminar screw. And that's much simpler, have got similar efficacy. And the strength biomechanically is very good. And then obviously, if you can put in a graft in the C1, C2 joint as well, that's then another addition. And on top of it, if you do require after that, then you can think about wiring at the back. The problem with wiring with the large bone graft is that half the time your bone resolves, and it's because of multiple factors. And so I think if you do a very good fusion anteriorly with C1, C2 fixation, along with you putting in a graft in the joint, then you can have very, very good results without any problem. And the chances of vertebral artery injury at C1, C2 have become negligible. We haven't seen one, and touch wood that we don't see one ever. But the reason being that it's very important to see where exactly the artery is going beforehand with an MR angiogram or a CT angiogram along with your MRI. And if you carefully study, then you'd know that, you know, even without image intensifier, you put in these screws, you do not need image intensifier for putting in these screws in C1 and C2. So it is relatively easy once you know the anatomy and you do understand your images.
Thank you, Dr. Salman Sharif. Is there any comment, any question from the colleagues from Mexico? And I am seeing that we have some colleagues from Latin America. Is there any question, any comment?
I think Omar has one from Syria. Hello, Omar.
Hi, Dr. Vigo. Dr. How are you, George? Hi, Dr. Salman. Dr. Tarif. I see for the vertebral column graft, this tumor is slowly growing, and this vertebral column the left. I think not need to make graft because make trouble in circulation in the brain. I think that. What are your opinion?
Yeah, obviously to confirm that you know, if can you sacrifice this vessel or not, you put in a balloon in that vertebral artery and you block that and see are there any changes, and you do that awake obviously. And if you don't have any symptoms, you can easily take it during surgery, or you can even, you know, leave the balloon like that and take the patient to theater and you've got the balloon in there. You don't have to worry because it's not going to bleed. So there are a couple of ways of doing it, and they both are fine. So if you know beforehand that you can't sacrifice it, then, you know, obviously your excision sometimes could be subtotal because you don't want to be giving stroke to that patient.
Thanks, Dr. Omar. John Bennett, do you have a comment?
No, thank you very much, Salman and Dr. Peeve. You guys are old time users of this technology. Salman was one of the first guys to really use the video platform with Google Hangout, right, Salman?
Yep.
Yeah, back in the day, I think we're in better hands with Zoom. I think that they're going to integrate virtual reality. I think they're going to integrate all these new technologies. So I appreciate you coming out. And Victor, do we have,
Yeah.
you want to wrap it up? Or?
Yeah, I want to tell you something. COVID disease in Mexico is going down little by little, little by little. So we are planning to make a congress in Acapulco Beach next August, probably first or the second week on August this year. So we invite you to take this congress. It was going to be a very which is one of the beautiful beaches around the world. The TV to World Spine Column Society. Salman, you are doing a very important. So much also to Nikolai Piv and the other colleagues that join us in this webinar. Thank you. College of a Mexican College of Neurosurgery is going to send you an accreditation of this webinar. So please send an email to the College of Neurosurgery in order to send you this accreditation to take this webinar. Thank you, Dr. Salman. I'll see you very soon.
Thank you.
Next Sunday. Thank you so much.
Yeah, definitely, definitely.
Thank you all.
Thank you, everybody.